of Fertility Fact or Fiction. Welcome to our show this week. We are so glad to be back on with you and looking forward to a great episode where tonight we are going to discuss whether your LH surge timing in reference to the implantation of a frozen embryo makes a difference. So can it be day 5? Should it be day 6? Or should you wait all the way out till day 7? So we have a wonderful, interesting article to review and some great data to look over. And we will go over all of the information with you. And then as always, we will allow you to ask your questions live and we can answer those usually here. And I have a little bit of interesting follow-up information for some of you that we're quite excited about whether or not car seats were a problem for your fertility. So we'll go over that as well because it seemed like we had a huge number of people asking about that last time, and we'll review that on the show. So make sure you click that subscribe button down below. And if you like the show, hit like so that we know that we can continue on with the path that we have. So the article tonight is one that's coming out. As you know, I'm usually kind of ahead of the curve for you guys to review things with you that are not yet even available. This one is by Vida Gavrik-Lovrik, and she is a PhD professor in Europe studying follicular biology. And the study is called Clinical Outcome of Vitrified Warmed Blastocyst Transfer, so those are frozen embryo transfers, performed on days 5, 6, and 7 after the luteinizing hormone surge detection using urine tests. So this is a retrospective study. They're looking back at data from their center. And then they did this thing called propensity score matching to be able to compare the different groups and see how they worked out. So interesting study. No one has really published this quite in the same way. People have looked at normally doing LH plus 6 or LH plus 7, but the authors have a really interesting argument here, which is we don't exactly know the timing of the LH surge, but in about 2/3 of women, it's going to happen from 7:30 p.m. till morning. So you've got that kind of 12-hour window. And then the actual surge itself can take actually quite a long time, as long as 40 hours to occur and sustain itself. And then there's the release of the follicle, after which you start producing your progesterone. So that whole process actually opens the window of implantation up from a really narrow time, which the people from iGenomics who support the ERA test will tell you, to actually quite a long time in a natural cycle. And the reality is it's probably not supposed to be any different when you're doing a frozen embryo transfer. You should really ideally be looking at the same kind of biology and the same outcome. So on the one hand, you have people saying there's a very narrow window of implantation. The ERA people claim it's 6 hours. And then on the other hand, the biology would suggest it's actually potentially days. Certainly the window of implantation is considered to be optimized around day 19 in a classic 28-day cycle. And then you should be able to have about another 4, maybe even 5 days of time during which the progesterone is high enough that there's a reasonable chance for the embryo to implant. So based on this, these authors looked back at their own data, examining what happened to patients where they transferred them on different days, whether it was day 5 after the LH surge, day 6 after the LH surge, or day 7 after the LH surge. And they wanted to see what the outcomes were. So essentially what they did was they looked at about 2,700 cycles that had frozen embryo transfers. And for the lack of available data, they had to exclude about 700 candidate cycles. Now that's a big methodological problem, because you're losing over a quarter of your data set. So that's an enormous data set loss. And it narrowed it down to just over 2,000 cycles that they had available that were there for examination and for data analysis. So in terms of how they ran their cycles, you can have a modified natural cycle or you can have a true natural cycle. Modified natural being you get some hormones depending on what's happening, and a true natural cycle being that you're really not getting any hormones whatsoever, aside from some progesterone support. So they basically used only decent, cycle monitoring cycles. They monitored with just a urine kit. So women were checking their urine every morning to determine this. They used blastocysts that were vitrified. So that's the freezing technique that was used. It's not slow freeze, but only dinosaur programs are still using slow freeze. Nobody should. It's known to be detrimental compared to vitrification. They only used blastocysts that had at least 50% of their cells alive. So they were pretty reasonable, and they had to be at least beginning to re-expand, which is another reasonable criteria. And then they analyzed the embryo transfer outcomes based obviously on the success from the HCG. They looked also at chemical pregnancies, clinical pregnancies, live births, and they also examined miscarriage rates. So the data, which I'm going to share with you in a moment here, I'll just pull up the graph, is right here. So as you can see, and I'll just expand that a little bit to fit the margins. So this is table one. So in table one, what they did was examine all of the various elements of the demographic. So things like age, their diagnosis, the day of the LH surge, you're using the urine test in terms of where in your cycle the actual LH surge occurred, how many cycles were difficult embryo transfers, the number of blastocysts that were transferred. They pretty much looked at every single thing that they could. Optimal blastocyst morphology, optimal proportion of blastocysts vitrified on day 5, like every single thing that they could. They compared to make sure that their groups between those in day 5, those in day 6, and those in day 7 were even. So what kind of numbers are we looking at? Well, the day 5 group had about 380 patients. The day 6 group, which was their most common group, had 1,610 patients. And the day 7 group had just 90 patients. So that's a little bit more rare for this group. So when you look at all of this, what they showed was that there is no statistically significant difference in any of the demographic characteristics of the 3 groups. So in other words, these groups were all very equally matched in terms of all the characteristics that they looked at, because there were no differences between any of them. So based on that, it made it a little bit of a more valid comparison, because now you're comparing apples to apples. Everybody had the same quality blastocysts, the same number of blastocysts frozen, the same number of blastocysts transferred, the same endometrial thickness. There were no differences. So that's really good, because that helps us say, hey, we're looking at the same pieces of information when we compare them. So just scrolling down, you'll see this next chart, which is table 2. Don't worry about those graphs at the bottom. Those are propensity scores, very hard statistical stuff to understand, but we're going to focus on the graph for now, the chart, sorry, for now. So when they compared the clinical pregnancy rates between day 5, which was 37.6%, day 6, which was 39.3%, and day 7, which was 31.1%, there was no statistically significant difference. And they actually compared this between all the groups and within the groups. So day 5 to day 6, day 5 to day 7, and day 6 to day 7, and there's still no differences between the groups. When they looked at the implantation rate, again, no statistically significant difference. So 34.3 for the day 5s, 35.6 for the day 6s, and 30.9 for the day 7s. When they looked at miscarriage rates, again, no statistically significant difference, 7.1%, 8.6%, 6.7%. And when they looked at the live birth rates, they were virtually identical, 30.5, 30.7, 24.4. Now, interestingly, when you look at that LH plus 7, it does look like there are lower numbers, but it's not statistically significant, which means there actually is no difference. Even though you see a lower number, it statistically is going to yield you the same chance. So they basically said that part of things is not really any different for any of those categories, regardless of whether you go on day 5, day 6, or day 7, you're going to get the same outcome in terms of the chances. When they did the propensity score matching, they essentially were looking to see, does it make a difference when you control for all of the variables that may be in there, like age and BMI and the number of times they've tried and all of those various factors. And they demonstrated that even with that propensity score matching technique, there was still no difference whatsoever between any of the groups. You still ended up, even after controlling for the confounding variables, with the exact same outcomes. And that means that you're still going to get the same chances whether you go on day 5 or day 6 or day 7. The reason I looked into this was I recently had a discussion with someone from the UK, and she said her program was doing it just 3 days after the LH surge, which was very unusual, or at least starting the progesterone at that time. The reality is that you can go on a day 5 or a day 6 or a day 7 and still have reasonable outcome based on this study. Where are the flaws? Well, number one, they lost a huge amount of their data set, as I told you earlier. Number two, this is a retrospective study, which means they had their data and they looked back in time at the data set. The right way to do this would be to be doing this prospectively, meaning you take your patients and ahead of time establish the same parameter where you say, we're randomly going to assign women to one of 3 groups, day 5, day 6, day 7, and then prospectively analyze what the outcomes are, because that's a much more valid scientific basis for what we're expecting and what we should be seeing from these groups. So those 2 elements are pretty critical. We lost a lot of data. We have a retrospective data set, but it's certainly a valid basis with which to start one of those studies looking prospectively and on which to decide. But the important thing for you is if your center says, hey, you need another day, or you need 1 day less, or we're going to time it like this or like that, it's not going to make a difference to your cycle, guys. You're going to get the exact same outcome from that natural cycle, regardless of whether you decide to go with day 5, day 6, or day 7. And I think this is very valuable information, not just for those of you who want to pursue a natural cycle, which is a great approach to things, but it's also really important for all those people that keep asking about the ERA test. This is yet more proof that the ERA test is epically useless, because over an entire 3-day span, they're showing that there is no difference. So why on earth would we think that something like the ERA can narrow your window from 3 days where you're getting the same results to just 6 hours, which is what the ERA people are claiming? So keep that in mind as you're analyzing this. You can watch our videos on the ERA. We have several. We'll put up a link for you and check that out. And for sure, that'll help you understand why the ERA test does not appear to work either. So I hope you enjoyed that segment of the show. Make sure you click that subscribe button, especially on our YouTube channel, which grows rapidly every day. And check out all our other videos there. In particular, check out Embryo Math if you want to know what your chances of success are when you're trying an IVF cycle based on your age. It's a hugely helpful video. Loads of people have watched it. Great feedback. So hopefully that will help you guys out and help you on your journey in the near future. Thanks again for watching that segment, and we're going to take your questions live.
First question.
Yeah.
Bed rest after FET. Feet up against wall for blood flow. Thank you.
So bed rest after FET has been studied quite carefully. There is no need to observe bed rest after an FET. In fact, you can get up and pretty much run around and do whatever you want to do at any point in time, and it's not going to have any impact or adverse outcome on the outcomes. What we believe is that the less stressed you are, the better you will do. So if bed rest stresses you because you're sitting there and you're on Google every 10 seconds looking up every single thing, then don't go on bed rest. And conversely, if being at work stresses you, then go home and chill out. But whatever stresses you the least is probably going to be the most beneficial thing for you. I don't think it's a function of rest versus not rest. As far as putting your legs up for blood flow, yeah, don't do that. That's a really bad idea. You know, we don't need your blood flow to increase that much to your uterus. And if you keep your legs up, you're actually making a lot of acid production in the parts of your legs that are not receiving adequate blood flow, in which case the little bit of blood that's circulating through there is becoming very acidic and hypoxic, and therefore is contaminating the rest of your blood, which is a disaster. So I don't know who came up with that idea, but definitely do not hold your legs up in the air after an FET. That is a very, very bad idea. You can do it after you've had sex and you want to keep the sperm in, but you don't need your legs up. You just need your pelvis tilted. So we normally just tell our folks to jump online, go to liberator.com. They sell these wedges amongst many other things that they have there. And you can buy those wedges and just tuck it underneath you and it'll tilt your pelvis up. You can dangle your feet like normal and it'll work great.
How long does it usually take to get DNA frag results?
Well, it depends on where it's being done and how it's being done, but typically a couple of days and you should have your results. So there are some times where it takes longer, but typically it's fairly quick. If it's being shipped out, for example, we use Fertiliser for a lot of our patients overseas. It usually takes us a week or two to get answers. If it's being done in-house, it's definitely faster, but we do tend to run it in batches. So sometimes they'll freeze it and run it afterwards.
Hi, Dr. Victor. Thank you so much for all you do.
Well, thank you.
What's the next step after a myomectomy for IVF? My age is 40 years, and what preparation I should start for it? Thank you.
So good job getting a myomectomy. That's a great start. Once you've done your myomectomy, you probably need to do a saline infusion sonohystogram to make sure that the cavity of the uterus and the body of the uterus are healthy. And then in terms of preparation, if you're doing IVF, you don't need any uterine preparation because you should definitely be doing frozen embryo transfer at 40. You do need pre-implantation genetic testing. So the uterine preparation isn't necessary, but from your basic health, you want to make sure you're eating healthy, you're exercising regularly. If weight's a concern, bring your weight down into a normal range as much as possible. Take loads of vitamins and supplements. Stay very low stress. And depending on how strong your ovaries are, there may be specific elements that need to be added, like DHEA or human growth hormone. Some people do estrogen priming, letrozole priming, testosterone priming. All of these things are possibilities for you that you need to look at. And then go through your IVF cycle, make sure you get your embryos tested for genetics to make sure they're normal. Once you're coming back around to the point where you're ready for your frozen embryo transfer, you need to make sure that they're doing a good job getting your uterus ready with probably as little estrogen as possible, because you don't want to be giving yourself something that could potentially stimulate either the really little fibroids they left behind or new fibroids a chance to form. Not that they're going to grow that quickly, but you don't want to be stimulating them under any circumstances.
Hey, Dr. V, is it useless to get your progesterone tested on day 5 instead of day 3 before an FET? I had to ask my doctor, and it took 3 days to get the lab test.
Wow. No, it's not useless. I guess if it was super high or super low, you could consider canceling. Did she say day 3 or day 5 before, or day 3 or day 5 of progesterone?
On day 5 instead of day 3 before an FET.
I don't know if she means 3 days or 5 days before, or on day 3 or day 5. We normally test ours after 3 days of progesterone. If you did it 5 days before, which would be day 1 of progesterone, that's useless because it's too early. Your body hasn't even had a chance to adjust to the progesterone you're taking. If you're doing it on day 5, which is 1 day before your embryo is transferred, that's plenty of time to A, adjust, and B, cancel before your embryo is thawed. So that's a great plan. I'm totally supportive of that.
I want a Facebook immune group.
Okay.
Some ladies say that we should retest our NK cells to check if they have increased after intralipids, as apparently it can make things worse. What are your thoughts on this?
I'm not aware of any evidence that suggests that NK activity gets worse after administration of intralipids. I am in communication with the doctor from Fertiliser fairly frequently. I got to talk to him tomorrow at lunch regarding 2 or 3 of our patients. And the reality is that when they do their immune tests, they actually test NK activity in response to intralipids for every single case that they have. I've never seen one that says that it increases. They may say it didn't respond or it did respond, and almost always it says it did, but I've never once seen them say that it increased. So I'll ask them, but I mean, they're doing that test constantly. So if NK cells were going to go up, you'd probably see it in response to the intralipid infusions. So I'll definitely ask them, but I'm not aware of any data that says that. It would be very difficult to test as well, because if you're doing your intralipids correctly, you're doing it before your transfer. If you're talking about uterine NK cells, you can't do a biopsy before a transfer. If you're talking about serum NK cells, the question then becomes, how relevant is that to what's happening in the uterus? So it's an interesting kind of question, but not an easy one to answer for sure. That would be very, very complicated and require its own actual study. But I'll ask Panagiotis, who's the guy from Fertility, Veneriatos. He's got the coolest name.
That is a cool name.
Panagiotis Veneriatos. Yeah. All right.
Hello, Dr. Victory. Hope you're doing well. I'm on day 18, about 30 to 33 of my cycle, and I had some light bleeding with mucus. Is there a reason for concern? Thank you.
Women that get some light bleeding around the time of ovulation, which it sounds is what you had, it's fairly common. There is some support for the fact that that can happen pretty commonly. As long as your lining is remaining mature, triple layer, it's got a normal texture to it, and on ultrasound that looks normal, you're fine. If you have an atypical lining and it looks like you're either getting too much estrogen, not enough estrogen, too much progesterone, etc., that could have long-term concerns, including things like hyperplasia of the lining. So I would definitely recommend you follow up with your doctor if it's persistent, but it's not a concern if it's just once in a while. The only thing that concerns me about what you're saying is your cycle is a little bit longer. So if you're getting out past 35 days between cycles, that's definitely concerning for the potential that, that's not a typical cycle, and that could be anovulatory or oligoovulatory, in which case those hyperplasia risks massively increase. So make sure you get checked out, see one of us, and we'll help you through that process.
Question you love.
ERA.
I have my ERA results from a medicated cycle.
No!
And my results showed
Yeah.
I need 132 hours of PIO.
Right.
If I'm going to have a modified natural transfer, am I going to need 6 days of PIO as well?
So ignore your ERA test. The ERA test has been proven to be useless. I apologize that you spent the money. I feel bad about it, but the ERA test is not a useful test. So based on the study we just reviewed at the beginning of the show, whether you do it at 5 days with a natural, 6 days with a natural, or 7 days with your natural LH surge, it doesn't make a difference. So the ERA test is not telling you anything of value. And that's been proven time and again. There are so many studies of ERA, all of which have shown no benefit. It's actually very odd that the company is still promoting it. I don't actually understand how they can. There's no scientific justification for it. Their own study showed that it doesn't work. So how they're trying to make a scientific claim from this is utterly beyond me. So don't worry about your ERA. Just go with probably an LH +6 if you want to be extra cautious, and you'll have plenty of progesterone there. If you're doing progesterone and it's a day 5 embryo, you should be doing 5 complete days of progesterone, so 120 hours, and then do your embryo transfer. If it's a day 6, you should actually be going 144 hours.
Hey, Dr. V.
Hey.
Could you also explain if Alice-Emma tests are useful?
Alice and Emma tests are a little bit better. Again, we use Fertiliser only because I find it's much more comprehensive than Alice and Emma, and it does not require a biopsy, which Alice and Emma do. But it works, fine in terms of telling you your bacterial composition. So it's a more reasonable test, but I'm a little more fond of what we get from Fertiliser, so we use them. I'm not against Alice and Emma as much. If you can use it to direct correcting your microbiome, that'll be helpful. The problem with all of these tests, including the Fertiliser testing, is we're not sure if when we treat the patients that we're actually getting rid of stuff. So actually, the nice thing with Fertiliser is they have a follow-up test, which is way cheaper than the initial one, literally a third of the cost. And then we check to make sure we've actually treated our patients. And in about 80 to 90% of cases, we do successfully complete the treatment. In 10% or 20%, we got to do it again. So it's nice to have that follow-up to make sure that you're actually getting the result that you want. And they send you these brilliant reports which say, you know, you're okay now or you're not okay now. What's next? Hi. I love the fact that you all say hi. Thank you. Hi to all of you.
Week 6, pregnant.
Yeah.
Nervous ahead of Friday's ultrasound.
Okay.
Odds of a miscarriage. No history of MC.
Miscarriage. It is very age dependent. Overall, 1 in 6 pregnancies will result in miscarriage. So it's not uncommon, unfortunately. But, you know, once you're pregnant, I mean, you've got obviously a 5 in 6 chance of remaining pregnant, which is quite high. So, you know, it's like an 83% chance you're going to be fine and a 17% chance things may go a little bit screwy on you. So it's reasonable. I mean, it's completely okay to be very, very hopeful and expect that the outcome of your pregnancy will be completely normal. So I would not worry about that.
How did DNC November 13th? When can I start trying to conceive again?
Right away. There's no reason why you can't start. Once your period comes back, you should be fertile and you can try again.
Well, I think this is answering your question. On day 5, my FET is the next day.
Oh, on day, so this was the patient that was asking about the progesterone. So yeah, you can check on day 5 if your FET is the next day, because if your levels aren't right, then you can adjust them on that day still as much as possible. We like more time, which is why we do day 3, but you still have time. It's just a matter of making sure you're not too low or too high. Too low is easy to fix. Too high is a little bit harder to correct that quickly. So yeah, it's certainly reasonable to do it on day 5. If that's all you've got available, it's better than nothing.
When should you be concerned about secondary infertility?
Secondary infertility is 6 months of trying without success. So if you've been trying for 6 months without success, you should probably follow up with someone.
Taking prednisone and trying to get pregnant, is it safe?
Yeah, it's safe. It depends on how much you're taking, though, because it can interfere with your ability to get pregnant. For some patients, if you use just the right amount, it's beneficial. And for other patients, if you're using too much, it could definitely inhibit things. So your dose is important. Your actual biology is important. Whatever problem there is important.
Ari wants to do a natural FET without any hormones. I'm nervous about not getting any progesterone. Is there a difference in outcome from completely natural FET to adding progesterone?
Yeah, so even with true natural, the recommendation is that we still use progesterone, because you're probably not producing enough progesterone on your own. And therefore, it's entirely reasonable to use some additional progesterone to make sure that the embryo is locked in and is going to stay there and give it the best chance possible. So most people who are doing a natural cycle will still add in the progesterone. They may skip the estrogen, but most people will still do the progesterone.
Hi, Dr. Victory. How much HCG is used for an HCG wash? And on average, how long would the HCG show on a urine test?
So 500 units is going into the uterus if you're following the most common studies. And on a urine test, it shouldn't really show. On a serum test, we have seen a hint of HCG even up to 5 or 6 days later, but I would not anticipate it would show up in your urine. If it did, it would have to be only a very few initial days, and nobody should be testing that early anyways. So I'm not expecting anyone to be checking for whether or not they're pregnant 3 days after with a urine test. So certainly a week or two later, you're not going to be seeing a urine effect from HCG wash. The concentration is just too low and the half-life too short.
Split cohort with IVF, round 1.
Okay.
Thoughts on estrus priming for IVF, round 2.
So what the questioner is asking is, or saying, is that the group of eggs that she had did not all kind of grow together when she did her IVF. And so she's wondering if estrogen priming will help line up the eggs so more of them grow together in the same phase. So estrogen priming is very reasonable for that. If you've got a low ovarian reserve, you can't really use the birth control pill, but if your ovarian reserve is good, the birth control pill will do the same thing. The alternative is to just do duostim as well if your cohorts are quite disparate, because then you can pick up your other follicles in the luteal phase and still get a great outcome from that. So you have multiple choices. Estrogen priming is a reasonable one.
Hi, Dad, I love you.
Who's that from? Nassim or Jenny?
Jay Victory.
Oh, hi, Jay. I love you too. Why the hell aren't you in bed, kid? It's 1 a.m. Go to sleep. But I love you, honey.
Beta is tomorrow, and I have had 5 days if faint positives. Am I doomed?
Beta is tomorrow, and I've had 5 days of faint positives.
Faint positives. Yeah.
No, you should be good. I mean, it depends on how far out you are from the actual transfer time, but you might be okay. So I don't put faith in a chemical indicator that is qualitative and not quantitative. Remember that the ability of a urine dip test to indicate the level of your beta HCG is extremely limited. So, and there are so many factors that go into it, including the concentration of your urine and how much you've had to drink and so on. So don't put a lot of stock in how dark or light your line is. Just the fact that it's positive or negative. If it's positive or negative, that's great. It's a qualitative test. Yes, no. But for a quantitative test, you need a blood test. There's no other substitute for that.
London Fertility Concierge says hello.
Hi. How are you, Mel?
31 weeks and having Braxton Hicks frequently. Went to the hospital and service looked good. Do some women just get a lot of Braxton Hicks?
Yeah. And unless they're painful, don't worry about them. So if you have painful contractions, definitely go to the hospital. But if they're just tight and it's not rhythmic, like every 5 minutes or getting stronger, in general, I got to choose my words carefully here, it's not a problem, so you don't need to worry. But if you're ever concerned, always go to a hospital and get checked out. That's what OB triages are for. But they're probably going to turn you away if you're only tightening and it's not painful, because most likely your cervix will not be changing under those circumstances.
What should your progesterone level be to transfer for a day 3 embryo?
Your progesterone level should always be roughly the same, although it hasn't been studied as much for day 3. And in theory, it is going to be a little bit lower on day 3. But what you're aiming for is the fact that the day 3 embryo won't fully attach till day 5. So on day 5, you want it to be 40 to 100 nanomoles per liter or 10 to 30 nanograms per mil. So you still want to establish that ahead of time. You could maybe go a little bit lower on day 3 and then ramp it up, but in reality, you need enough time to get it to adjust. So just keep it at the same level the whole time.
After having a nasty cold for a couple of weeks, strutting is back to normal, except I still have a slightly stuffy nose.
Okay.
Anything I can take to make it better? Everything, not strutting. I'm 23 weeks along.
Strutting?
Yeah.
Um,
Everything. Oh. Everything is the asterisk for what strutting used to be. So if weeks, everything is back to normal, except I still have a slightly stuffy nose.
Oh, okay.
Anything I can take to make it better?
Vicks Vapor Rub, Hall's Candies, vitamin C, vitamin D, echinacea, Cold FX, which is just a ton of ginger, basically. Anything natural that you want to use is fine. Tylenol, Yeah, lots of fluids, old-fashioned remedies.
It's hard to correct these things when they send it, and then it's the next message and the next message. It's tricky. Hey, Dr. Victory.
Hello.
We are doing a monitored cycle and timed intercourse.
Okay.
I have a 22 millimeter follicle.
Awesome.
Was advised to trigger and have sex next 4 days.
Okay.
We have make factory, so wouldn't 4 days be too often?
We have made factory?
We have make factory, so wouldn't 4 days be too often?
Oh, male factor.
Must be.
We have male factor. So in
Another
every day
yes.
be too often? No. Whatever sperm is there, you want to keep ejaculating. So have sex kind of the day that you trigger, the next day, and the next day, and the next day, and that's fine.
They corrected male factor.
Yeah, they've actually got studies of men with relatively low sperm counts, which shows that unless it's very severe, the sperm count does not significantly diminish even if you go every day. You can do that for like 4 or 5 days and it's fine. If you go beyond a week, it starts to decline, but for 4 or 5 days, it's fine. So go ahead, not a problem at all.
Hi back to you, Dr. B. We love you. Do you have
I love
to
you
wait
too.
14 days after an FET for your beta, or can it be done sooner? Thank you for your answer.
Thank you. I love you too. And the answer is no, you don't have to wait. I'm going to set the internet on fire here, but there's a new type of beta HCG, which they claim you can test as early as 5 or 6 days after. I'm just looking into it. Please don't flood us with questions. I don't know if our machine will even be able to run it, but we might start considering that. But the reality is that your level is really optimally done 14 days later so that we can make sure that it is a valid test and we're not just seeing, the likelihood of a chemical or a false negative or a false positive. So that's why we choose that 14-day mark. And it's close to what you would normally anticipate as being a few days after your period was late. So it's kind of mimicking, what you would naturally expect. But it can be tested earlier. A very good bioassay can check it as early as about 8 days of pregnancy, which is just a few days really after you've had a embryo transfer. If it's more of a conventional assay, as early as 8 or 9 days after an embryo transfer, you can probably pick up some beta. The problem is you're going to have to keep doing it serially to make sure it's rising. And we don't know how well beta HCG rises in the very early phases because it's not exponential in the first week or two. So it freaks everybody out because they don't know if it's okay or not.
How long is the wait for endolaparoscopic surgery with you?
The wait with me is totally dependent on when the OR gives me time. I love operating. Everybody that knows me knows that I love being in the OR. It's a lot of fun for me in the OR. We have a great time in the OR. And I pride myself on being reasonably good at doing that kind of advanced, minimally invasive surgery. So give me all the time in the world and I'll do as many cases as I can. Unfortunately, because of restrictions and COVID and right now reduced anesthetic opportunities from our anesthetist cohort, we just don't have that much time. So it's harder to get OR time right now. I'll get you in as quickly as I can, but we're at the mercy of the OR.
I asked about the split cohort. You mentioned dual stim. My next round is OHIP covered. Will they cover dual stim?
No. So duostim is great question, by the way. Duostim is 2 cycles in 1 month. So your OHIP could do the first one, and maybe depending on who you're working with, you could work out coverage to get the second stim for less. Unfortunately, in Toronto, I don't know everybody's pricing, but I know at least one place that actually had the audacity to charge more for the duostim than they do for 2 follicular phase cycles, which is quite frankly absurd. So you got to be careful where you're going because they may be gouging you. We actually charge less for a duostim than we do for 2 independent cycles, even though they're 2 independent cycles. because we feel bad for those people because they're struggling. So we brought our costs way, way down. But other places are actually charging more, which I find immoral. So don't go to those places, hopefully, or do your second half somewhere else, like us.
Do day 6 embryos implant slower? Thank you.
No. Day 5 and day 6 embryos in virtually every single study show equal potential for implantation and outcome. There are some studies that favor day 5, but generally speaking, day 5 and day 6 are equal in their potency and abilities. Day 7 is not as good. There's a big drop off when you go to day 7.
How long would you need to treat if your Fertiliser test come back positive for endometriosis? What antibiotic is usually used to treat?
So I don't think you mean endometriosis because your Fertiliser test comes back positive for endometritis, not endometriosis. But if you're looking at antibiotics, it depends on what bacteria you grow. So the two most common ones we use are amoxicillin clavulanic acid and then Flagyl. And we use those two either independently or in combination, depending on what's in the uterus and in the vagina. So those are the main ones we're using, unless you have chlamydia, in which case we have to use doxycycline. So it all depends on what's going on in there. And then they recommend 10 days to 2 weeks. I actually go for a month because it's very, very hard to get rid of stuff from the uterus. So normally you're looking at about a month. Then you got to repeat the sperm test, the infection test, and then you have to see if the bacteria has been cleared or not.
Does uterine lining stop thickening once you start progesterone during an FET?
Yes, it should and frequently does. Yeah.
8 weeks pregnant and on 600 milligrams of progesterone a day have a mild but constant period like cramps. Is this the progesterone or could something be wrong?
How many days?
8 weeks pregnant.
8 weeks pregnant? There are some women that complain of cramping from progesterone. So it's not unheard of to have women that are crampy from progesterone. But generally speaking, it's not the progesterone. It could be infection or it could be just the uterus stretching, which for some women makes it really crampy. So that's not unheard of at all.
Hello. How effective is position and feel of the cervix to determine pregnancy? For example, underwent an FET, blood work. Yeah.
No. Do not touch your cervix. You're introducing infection and you're introducing lots of opportunity for complications and bleeding. And there is absolutely no way anyone, no matter how skilled they are, is going to detect from looking at from touching your cervix if you are pregnant or not. Anyone that says they're doing that also is reading tarot cards and has a crystal ball. So that's utter garbage. There's no evidence that you can detect that. When I was in training, they used to talk to us about the fact that the cervix would gain a bit of a purplish tinge when you're pregnant and become a bit more engorged. No one ever classified when that was going to occur. And I can tell you from looking at literally dozens and dozens and hundreds and now thousands of cervices in women that are pregnant and non-pregnant, that's just simply not something I could ever distinguish looking at a cervix and saying, that one's pregnant and that one isn't. So you can't tell from that. Just get a blood test. Like, people are always trying to look for natural things when sometimes it's not necessary. That would be a brilliant example of where it is not necessary to reinvent the wheel. It's just a blood test. Go get your beta done. Find out if you're pregnant or not. Don't poke your cervix.
Hello, Dr. Victory.
Hello.
First of all, it was nice doing a virtual consult with you last Friday.
Oh, awesome.
We're looking forward to the next steps.
Okay.
Do you recommend getting the booster before doing IVF?
Yes, get the booster. I recommend everybody gets their vaccination because there is absolutely no harm in doing so. They've proven time and again that it's safe for patients who are getting pregnant or are pregnant, and there is no downside to getting the vaccine. On the other hand, if you get COVID, both male and female, it can significantly impact your fertility and, more importantly, your life. So don't waste a single minute. Go get vaccinated.
Hey, doctor, I did FET, positive pregnancy test. HCG, 7DP5DT equals 104. And 12DP5DT equals 1641. Are these good numbers?
They're
I've
excellent.
had multiple failed cycles despite positive tests at the start.
Those are excellent. That's totally normal so far. So you're off to a good start right now.
Any other tests to monitor?
No, I mean, as long as your progesterone levels are okay and this far out, they should be normal. You could continue to do serial betas. It might drive you crazy, but whatever will stress you the least is what you should do. So if you feel more comfortable doing your betas, then do your betas. And if you feel more comfortable just waiting for your ultrasound, wait for your ultrasound. Ultimately, nothing you do or we do at that earliest stage in the pregnancy will have any difference on the outcome. We can't intervene if the betas start going sideways on us. So, you're wherever you're going to be, and it sounds like you're in the right spot this time. So congratulations. Lots of thumbs up from the watchers.
At a clinic in Toronto.
Okay.
With 2 embryos left.
Okay.
Not confident in the care I'm getting.
Oh, that's not good.
Can I transfer to your care for my next FET, and how long would it take to get an appointment with you?
Yes, you can transfer to our care. I'm not sure about the appointment time, and I've sworn to my office that I will never answer that question on pain of death. But you know what? If it's a special case, just reach out to us. Email info@drvictory.com. and just say urgent, and they will triage you. They may reach out to you and ask you some questions, and they will get you in as quickly as possible. If you are down to your, as you quote, last embryos, those are cases I never want to rush, because normally I need to figure out what was wrong before you got to us so that I can make sure you do get the right care, and that can actually take some time. So I'd caution you to be patient in order to optimize success. One of the first things I do with so many couples is tell them to not keep pushing to go faster, but rather push to go better. It's not important how quickly we go. I can race through a cycle and it'll be a disaster, or I can spend an hour on the call with somebody in Europe and they're pregnant the next month because they just listened to what I had to say. So don't rush this kind of thing. Taking your time and getting answers is invaluable compared to spending all that money on making more embryos and then it doesn't work. But info@drvictory.com, and I hope Mara is watching this, because you cannot get me in trouble now. Go ahead.
Dr. Victory.
Yeah.
What is the expected age that menopause begins?
Average age in North America is 51. It's different from country to country, but average age in North America is 51. It is considered abnormal if you go into menopause before age 35. And if you go into menopause after age 51, it's not abnormal. It's just beneficial in some regards, but there's no downside to that.
And at this moment, at this second.
No questions?
No, hold on. Instagram had more waiting for you. False alarm.
All right.
And
I can talk about the electromagnetic radiation. We can set the web on fire. You know what? Let me talk about that. So because everybody was freaked out about their heated car seats, we got so much feedback about people upset that they should use their car seats. So I looked it up. So number one, if you're a dude, it is bad, like really bad. So do not heat the car seats. The heat is bad, and the electromagnetic radiation is really bad. There are lots and lots and lots of studies supporting the fact that the heated car seat is terrible for you. So my wife always makes fun of me for leaving the car seat heater off, even though we're out of the fertility range now.
Is this a fertility thing, or is it like a prostate thing as well?
No, I don't know about prostate, but it causes inflammation. Like it's bad for sperm. There's a whole slew of articles showing that it's bad. Yeah. So Tarek's already got lots of children, so he doesn't need to worry about it anymore. And I'm done. I'm very done. But the although we may end up killing my daughter who's up at 1 a.m. in Scotland, so maybe we'll need another child. In any event, the reality is that for women, there is less information, but there is information, and it also is not good. So avoid electromagnetic radiation if you are either pregnant or trying to get pregnant. And if you're a guy, definitely avoid it because it is bad for your sperm. So that's the news on electromagnetic radiation. Maybe we'll review a couple of. I know. I can't even look. I've got the studies right here. Mobile phone radiation, physiological and pathophysiological considerations. Lifestyle causes of male infertility, talks all about EMF related health problems. There's all sorts of stuff here. Impact of non-ionizing electromagnetic radiation on male infertility, an assessment of the mechanism and consequences. Study after study after study. I punched it in for a search and it came up with 40 different articles on this. So yeah, it's not good. Stay away from the heated seats. Sorry, guys. Do you turn yours on?
Yeah. Melted.
Never. I do not. Even when I wear scrubs, and believe me, ladies and gentlemen, scrubs are not warm. Even when I wear scrubs, I don't turn on the heated seat because I don't want to. I don't want to bake the boys. Yeah, the boys don't like to be baked. Okay, next.
After a failed FET, planning to do 3 months of Lupron before the next transfer. Do I continue to take all my supplements during the next 3 months? CoQ10, NAC, curcumin, etc. I'm assuming I should only stop the aspirin.
Well, you can continue the aspirin. It's harmless. But if you're on curcumin and NAC and all the other stuff, you're doing it for endo. So just make sure you're on letrozole and Lupron because it's not Lupron alone. That actually has been shown not to be beneficial. It's the combination which is beneficial. So you should be on Lupron and letrozole, and then the NAC and the curcumin and the coenzyme Q10. Aspirin's harmless, so if you want to stay on it, stay on it.
Thoughts on the Receptive DX test?
Lots of people asking about that. It's useless. Do not buy the Receptive DX test. It is unnecessary, it is unhelpful, and it is non-diagnostic. So we got to do one on that, don't we?
Absolutely.
We've had a lot of. Can you guys tell us, a thumbs up, how many people want us to do a Receptive DX review?
I want to double check your stats on the heated car seats.
Tarek wants me to do a talk just on heated car seats because he's worried. Dude, you have enough kids.
I'm not worried about them. Do I allow them to heat the car seats?
Oh, no, don't let the boys heat the car seats.
That's it.
Well, when they're little, it's probably harmless, but later on in life, yeah. It's cooking.
Growing.
Yeah, man, don't do it.
Do you have any insight about, this question again, the red light therapy?
Yeah, red light therapy apparently works. So red light therapy is not red light therapy, it's laser. And apparently it does have the potential to improve sperm performance. It's specific to sperm. I don't know how that works, but supposedly it can improve it. But I looked at the few studies, it's not like super, super amazing quality studies, but there is evidence that it's beneficial. You know what? I could probably pull it up on the iPad and show it, but ask me another question while I look this up.
Thank you so much for answering my questions and being so positive.
Oh, my pleasure.
There's actually a car seat story. I stopped using my heated car seats this past week, and I got angry at my husband, who turned it off for me while I was sleeping.
I have to turn on our heated car seat for my wife, or I get in trouble for letting it lapse while she naps on the way to the cottage. So, believe me, I am very familiar with the heated car seat thing.
I live in Ottawa.
Wait.
Oh,
Yeah. Pop me up here. Am I still? I'm not screen mirroring. Hang on. Oh, no.
I'll do it.
Yeah. We're gonna do the. There we go. Yeah. There we go. Are we connected?
Almost there. Don't start yet.
Do you want me to start singing Dua Lipa? Don't start now.
You know what? I think everybody would love to see that.
You need to put that song up for like 2 seconds so we don't get in trouble.
It's all yours.
Okay, so here you go. Look at that. Comparative effect of low intensity laser radiation in green and red spectral regions on functional characteristics of sturgeon sperm. Microwave and laser assisted. Oh, no, that's not what you want. God, there was a study here. That was one. What else is there? There's lots of these. The effect of low laser irradiation on sperm motility and integrity of the plasma membrane and acrosome in cryopreserved sperm. So we've got all sorts of studies here. Does low-level laser therapy on testicles improve post-thawed sperm characteristics? Differences in sperm protein. So anyways, there's loads and loads of stuff here. Photobiomodulation improves stereological parameters and sperm analysis factors in streptozotocin-induced type 1 diabetes mellitus. I don't even know if that was English, guys.
You know, it was a relief to hear you read a word that streptozotocin didn't sound just like me. It was a moment.
Anyways, there are loads of studies on laser therapy, as you can see, which seem to, make a difference. Here you go. Effect of 830 nanometer diode laser irradiation on sperm motility. Why are they always Persian when there's some weird study? I can recognize the names. Sohaila Borhani, Fatomars Farahi. Now I'm speaking with my Persian accent. Okay, so our results showed that irradiating human sperms with low-level 830 nanometer diode laser can improve their progressive motility depending on both laser density and post-exposure time. I'm going to have to show this to Fari, but maybe we're going to start zapping our sperm.
How's that?
There is data that it works. I looked at it for you guys because everybody wanted to look at this. That was like 2 years ago. People mentioned it. So yes, there is data that the laser works.
I'm 33 and wondering how long you have to try, parentheses, before referral to you specialist, working on baby number 2, healthy, no medications.
6 months if it's secondary infertility. So just come see us if you've been trying for 6 months and then it's not working. You don't have to wait that long. You can come whenever you like, but an honest fertility specialist, that would be me, would recommend that you wait at least 6 months before trying. That's assuming you're having regular periods. If your periods are irregular, see us right away. Or if your age is higher, see us sooner.
I live in Ottawa. My clinic is in Toronto, and I would like to know if I can be transferred to you. I'm scheduled to start funding IVF in February, March. Would transferring to you delay my start for IVF?
Yeah, so we don't have funding yet. We are hopeful that we will be getting it in, what's the date today? The 13th?
13th.
We might find out in 2 days. So we're hopeful, but we don't know. The reality is I can't offer you funding. So do your funded cycle in Toronto. We're still happy to help you and we can guide you through your funded cycle. But I don't really like to interfere with what other centers are doing. Nevertheless, if you want to transfer to us, we're happy to take care of you. I just can't offer you funding at this time, unfortunately. I wish I could. How long are we going? It's
you have like
9.
One, yeah.
One more? One more? All right, let's do Tarek's terminal question.
Ooh, I don't know if I have a terminal. I have a nice comment.
Okay.
Thank you, Dr. Victory. May the gratitude of all you help fill your home and heart with blessings and prosperity and in all you do.
Oh, that's very sweet. Thank you. That's very kind of you. That's very, very kind. Appreciate that. And you know what? Best wishes to everybody else out there too. God bless, and hopefully everybody stays safe with this holiday season, and a blessed holiday season and a blessed New Year too.
Last question.
Last question, sure.
How many cycles of IUI with donor sperm before moving on? My husband doesn't want to do IVF. We purchased 8 vials of donor sperm, hoping for 2 kids. starting cycle 4 and want to be realistic?
It depends on your age. So you shouldn't be doing more than 3 if you're over the age of 38, and you shouldn't be doing more than 6 if you're under 38. So those are the numbers, but it depends on your diagnosis too. I mean, why has it not worked? What did you try? What are your other features? You know, what's your overall health? What's your body mass index? Are you smoking, drinking? Is there drug use? Are you regular? What medications did you use? So there's a whole element to it. But certainly if you're on try number 4 and you're older than 38, you should not continue. If you are less than 38, you still have 3 more tries, 4, 5, and 6. So it's reasonable to continue. Can't promise you you'll have 2 kids, but it's reasonable to continue trying. Done. All right. Well, thank you all very, very much for joining us. Thank you to, we don't get any sponsorship here, but I like to throw free sponsorship out there. So thank you to Fertiliser for all the stuff you do for us. Thank you to New Urine that provided us with awesome Chinese food tonight. So our dinner was amazing. And thank you to Tarek from Ibrahim Strategies Group, my trusted friend, advisor, and confidant, who makes every night a joy when we're together, because it's hilarious. So you guys have a wonderful, wonderful week. We will be back next week with another show. We will be back next week, right? Next week will be the 20th. Yeah. So we'll be back next week with another show. I'll find an interesting topic. Maybe we'll do Receptiva DX. Let us know if that's what you want it to be, and we will be in touch soon. Have a great night. Take care, guys. Everybody go home and watch Yellowstone. See ya.